exam is unremarkable, but you definitely notice swelling in his right lower extremity as compared to his left lower extremity. Now that we've looked at that, as that kind of keys you in, what additional labs, imaging, or any interventions would you like to pursue for this gentleman?
Right.
Do you want
We should perform the ultrasound.
ultrasound?
Yeah.
Oh, okay.
Blood test. Yeah.
Blood tests.
Yeah.
Okay.
WBC and C-reactive protein. Yeah. For the infection.
Okay.
Maybe it's a cellulitis. Maybe.
Yeah.
Yeah. Or necrotizing vasculitis. Yeah.
Sure. Okay. Yep. Dr. Volman, any thoughts on any imaging or testing you would like to order? Oh, she's here too. You are also here. Sorry, my apologies.
Basically, I talked about the potential of the leaflet and the figures coming down in the blood pressure.
Okay. Okay.
And according to Dr. Anand, I will check the person blood pressure count from CRP to confirm the person. And I will, in this case, I will use the antibiotics immediately.
Okay. So it sounds like we're going to start
recording in progress.
We are, as you said, we're going to get some imaging. We're going to rule to confirm infection. We're going to rule out any signs of a DVT for your ultrasound. And also I agree with you getting some blood tests and some imaging, but also even though we see this here, maybe it's a vasculitis, maybe it is a cellulitis, we still have to keep our differential pretty broad, even if we think that we're localizing here with such a non-specific complaint of weakness. So our first interventions are establishing IV access. And so anybody who is weak, we recommend getting an EKG in case that this is a cardiac etiology for the weakness. I agree with getting the complete blood count, the metabolic panel. I would additionally order a troponin and a BNP to kind of still check that part. And then we'll get initial, possibly a glucose level, or if he seems stable enough, we can wait to see what our metabolic panel looks like. Get some blood cultures if we are going to start antibiotics, get a urine with culture, chest x-ray to make sure we're not missing a pneumonia or any signs of pulmonary edema that we may have missed on our physical exam. I would start off with an x-ray of his ankle and of his tibia and fibula just to make sure, see if we're not missing any bony structures. And also, at least where I work, you can get an x-ray much faster than you can get a CT scan. So to see if there's any signs of gas that are tracking along the fascial planes. And we talked about getting inflammatory markers. But in the meantime, also starting our interventions for likely sepsis and going along with the Surviving Sepsis campaign of starting with the 30 mils per kilogram of fluid bolus and starting antibiotics. And if you want to have a discussion, if you wanted to start antibiotics just for possible cellulitis, or that we don't have a good definitive source of if this is cellulitis versus something more sinister, about how broad your initial antibiotics should be. So we start getting our information back, and his white blood cell count is pretty high, but luckily he's not anemic and he's got okay platelets. He's hyponatremic, but we look down to his glucose level and we think that's likely borderline normalizes secondary to his hyperglycemia. His creatinine is slightly elevated as well as his BUN, but we don't have a great baseline for him. But he definitely has a metabolic acidosis. And we got a lactate with our blood cultures as part of our sepsis bundle when he came in because of his vital signs and his presentations made us concerned. And we also got a blood gas. In the United States, a lot of the times we'll do a venous blood gas instead of the arterial blood gas, just for ease of our nursing staff. And here he is acidemic. Yeah, so his and is confirmed with his bicarb of 15, but it looks like this is primarily a metabolically driven acidosis instead of respiratory. So then you got an EKG. Yep, tachycardic. Okay. Are we seeing any other abnormalities on this EKG besides that it is going fast? You're allowed to say no because it's just sinus tachycardia. So good job, everybody. You get a chest x-ray. For our trainees in the room, we go through methodically to make sure that we're not missing anything. Everybody is different on how they go through their chest x-ray exam. I look at the cardiac silhouette first. I start in the middle and then work out. Looks like this has a normal cardiac border. We're not seeing any cardiomegaly. The costal margins look sharp, so I'm not seeing any pleural effusions. I track back up and look for any cephalizations or increased vasculature, which would be suggestive of pulmonary edema, which we're not seeing here. And then you track along the external borders to make sure that you have lung markings all the way to the end and making sure you're not missing a pneumothorax. And then finally, I look at the bony structures to see if there are any underlying fractures. And then also it's very embarrassing if you miss gas underneath the diaphragm. So also be aware of what's going on underneath your diaphragm here and making sure you're not missing something that is obvious. But generally that is a normal chest x-ray. So it doesn't look like he has any signs of pneumonia on here. So our next steps. Is there anything else that you would get? We talked about maybe reaching for your ultrasound, getting an x-ray. So what are we concerned about for this gentleman?
Sepsis.
Sepsis, necrotizing fasciitis, because he had pretty good amount of pain when we pressed on his leg.
Yeah.
So we start antibiotics. At this point, you can have a conversation with your pharmacist about your clinical suspicion for necrotizing fasciitis and thinking about adding clindamycin for the exotoxin to help mitigate those effects. Depending on where you are here, I would recommend, and I think your surgeons would also appreciate, a CT, even if you find it on the ultrasound or on your x-ray. A lot of the times for surgical planning, they'll say they would like a CT of the limb or area that is involved. And then I think here a lot of the times your nurses are very helpful. In our place, we often do it as the physicians is put a skin marker and a time so that when you come back and you reassess your patient, as the patient we saw yesterday, you can see how quickly that area of erythema is spreading. So on reevaluation, your patient, after the fluid bolus, the heart rate has come down. The blood pressure is about the same. They're still a little tachypnic, and their temperature has gone down because you luckily gave them an antipyretic. But you go back and you look, and now that small area of redness has gotten larger. And you forgot to put the marker on the first time, so now we're putting the marker on. Okay. And at this point, with how quickly this has spread, now what? Who are you calling?
Consultation with the orthopedic.
The orthopedic? Okay, yeah. So yeah, I agree. So it's your surgeons and depending on your hospital of who takes care of it and what area is affected, can be multiple surgery specialties that are involved. But here, normally it is the orthopedic surgeons, and then they'll have a discussion about how deep it is if they need to go in and amputate versus being able to go in for early debridement. With how quickly this is spreading, we also have to think about making sure our antibiotics are broad enough that we're getting frequent reevaluations of this patient to make sure that it's not spreading up the limb faster, which hopefully we could communicate to our surgical colleagues to take them in to be evaluated sooner in the OR. And then also making sure that they're hemodynamically stable. And then our job is to fix the things that we can fix in the emergency department. If we remember, this patient, when they came in, was pretty hyperglycemic. You gave them fluid bolus and it came down by about 70 points. So now he is reading about 370 for his glucose reading, which is still high. So he doesn't take any insulin at home, but this is somebody who you want tight glycemic control because that hyperglycemic state is also contributing to the spread of the infection here. So good job, everybody. You called your surgical colleagues. They said, we don't need a CT scan. Just kidding. But you got the CT scan and it did show that there was a gas-forming organism in there, and they took him to the OR and they were able to spare his leg. So what were we talking about here? This is necrotizing fasciitis, or necrotizing skin infection, which has a very high mortality rate. More chairs here. So anytime you have somebody who comes in with an area of erythema, I'm not saying that it has to be on the differential, but it should be. It should be something that you at least have in the back of your mind, because missing it can have very severe consequences. So the risk factors include people with diabetes who are immunosuppressed, either from chronic steroids, your transplant patients, your patients who have cancer, if they don't have great nutrition status, if they have a history of IV drug use or alcoholism, or those who use chronic corticosteroids. There are some very low-hanging fruit for triggers. So any type of trauma, recent surgery, so iatrogenically that we did something there. If they have a virus, that may also affect how their immune system is able to respond to any type of infection. Local skin damage, and then in infants, if any of the trainees decide to go into pediatrics, is making sure that also kids can be at risk for this as well. It's not just for adults. To notice that it can take up to a week from that initial trigger to progress. But once it starts progressing to the form where it has rapidly increasing erythema and pain out of proportion, from that point, it can increase very quickly. And mortality doubles after 24 hours when it starts to get to this level of presentation. So on the side here is just remembering that most of the time that these infections are polymicrobial, they can be due to either group A strep or the Clostridium bacteria, which is often what forms that gas in there. But as we talked about yesterday, and then a few days ago for our colleagues over at Chorai, is that you don't need gas in the tissue to declare it as necrotizing fasciitis. And remembering to start your broad spectrum antibiotics early, including a clindamycin. You want to have a broad beta-lactamase or carbapenem, and then vancomycin or something for MRSA as well. And then treating shock if they begin having a shock state and signs of end organ damage, checking on them frequently, because this spreads very quickly and can cause hemodynamic instability. So the number of cases in the United States is much lower than what it sounds like you are seeing here. Most of the time it's 1 to 15 per 100,000 individuals, but it's likely underreported because, as sometimes we said, this can be insidious and people might not recognize it until later in the course, as that's the cause of a patient's septic shock. But most of the time, at least for the literature that I saw, it was primarily polymicrobial as well as due to group A strep. But again, everyone believes that this number is likely underreported as it's not being fed into many of the overarching data systems that are following disease cases. So we talked about the risk factors again. So chronic diseases, immunosuppressive drugs, especially those on steroids, those greater than 60. As you start getting older, you start collecting your comorbidities, which can make it more likely for you to have the faster progression of necrotizing fasciitis. But they found almost 25 to 30% of people did not have any comorbidities. So although these risk factors may raise your suspicion for an underlying necrotizing fasciitis in someone with erythema of a limb or of an area, just because they don't have these risk factors doesn't mean they can't have necrotizing fasciitis. Also, a lot of the times we talked about is that they'll come in with very non-specific symptoms. They're weak, they're tired, maybe they feel easily fatigued or winded when they walk around. So these systemic symptoms are very nondescript, but when you take them and get their vital signs, you find them to be pretty sick. They can be tachycardic and hypotensive and just borderline shock, if not right into the shock state when they present. And we talked about, I want to call attention to the blister villi formation in stage 2, because there are a couple of differentials we have to think about when patients present with bullae. And necrotizing fasciitis is just one of them. You still should go through your good examination of a limb, make sure your compartments are soft, that you're not missing the compartment syndrome, making sure that there aren't any new medication changes, that you're missing something like an SJS or a TEN, which can often start with just a single bulla formation and then rapidly spread as well. So just being aware to keep your differentials pretty broad. Do you use the Lernick scoring system here to help with stratifying?
Usually.
Yeah, okay. So for our other learners that are on here, the Lernick scoring system focuses a lot on the use of your lab tests to help stratify the mortality of your patient with suspected necrotizing fasciitis. So on the left, we see the parameters, and then on the right, it correlates to the identification of necrotizing fasciitis based on their Lernick score, and then how likely they were to have these physical exam findings and the presence of necrotizing fasciitis on imagery. So it's fairly specific, but not always sensitive. You have to have that clinical suspicion, because as we talked about, the Lernick score focuses a lot on your laboratory tests, which can be deranged for multiple different etiologies of anybody who is also in septic shock. So you have to have that clinical suspicion of an area of erythema or an area of pain, and then you can use your Lernick score sometimes to help your case when you talk to your surgical colleagues, to help you communicate how concerned you are about them having necrotizing fasciitis and the correlation of your concern for their mortality rate if we don't act quickly. As I said, at least in the United States, the few cases I've had where I was concerned enough about a necrotizing fasciitis, I had somebody who was very similar to this case who came in with a rapidly expanding area of erythema on his legs, very low trauma mechanism, bumped it against something, but did have some risk factors. We had surgery come down and evaluate them before we had any of the laboratory tests back because we had that high of a suspicion. So it just depends on how busy the surgical service is for that day and a lot of the times who was on call. So, quick question. If your CT scanner is unavailable, how can you next manage a suspected necrotizing fasciitis or necrotizing soft skin tissue infection? Would you call the surgeon, start antibiotics, get an x-ray of the limb, use your ultrasound, do a finger fascial plane dissection, or can you do all of the above? All of the above. Okay, Perfect. Yes. All of these are good answers for things that you can do if your CT scanner is not working. So as we talked about last couple of days, we have on the right our ultrasound. What findings on here are concerning for a necrotizing tissue infection?
Tiny gas on the X-ray.
Yeah.
In the soft tissues.
Yeah. So there's gas tracking along here, up along kind of a fascial plane. This is not normal. This is not edema.
Yeah.
That is gas. Like down here, where's my thing? Can you see it here? Down here, we have some signs of edema, but this presentation, oh my goodness, is wandering here. This is gas.
Yes.
And for the learners, this is just a calcified vessel. This is not gas. This is your calcified vessel. Yep. Yes, Dr. O2. Yep, gas. And then on the right-hand side, we see gas in the ultrasound. As we talked about earlier, these bright white lights with some hyperechoic shadowing, followed by the dirty shadowing with the obscuring of the tissue behind. We're also starting to see, I know this moves very quickly. Here, when it goes through, there is a linear aspect to the fluid overlying the area of gas. So you have multiple modalities at your disposal here in the emergency department to help coax your surgical colleagues when you have a high suspicion of necrotizing fasciitis. So we're going to go on to a second case. We have an 84-year-old female. She has a history of COPD. She also has type 2 diabetes. She has coronary artery disease, and she was recently hospitalized for COVID pneumonia. Is coming in with shortness of breath and fatigue. She was just discharged less than a week ago. She is fairly tachycardic. She's beating 135 times a minute. She is hypotensive at 89/62. She is breathing 23 times a minute, and she is satting 89% on room air, and she is febrile. Her airway is intact. She is tachypnea when she speaks to you, and she's got decreased breath sounds at bilateral bases. She's tachycardic. This is an irregular rhythm for her. And she has warm extremities and bounding pulses. So a little bit more information is that we have this 84-year-old female. She was sent home a week ago after a prolonged course of COVID pneumonia requiring hospitalization. She was discharged home on 2 liters nasal cannula, and she just decided to forget about it on her way to the emergency department. But for the past 2 days, she's had difficulty with walking around. She's been weak. She's been having some muscle aches, chills, and now some new shortness of breath. Luckily at home, she hasn't fallen or lost consciousness, but she does say that she sometimes has chest pain when she moves around just a little bit. She's had some chills, but no change in her baseline cough, no current chest pain, no nausea, hasn't thrown up, and no loose stools. She doesn't have any abdominal pain and has had no change in her urinary frequency or dysuria, and no one else is sick at home. What are your differentials for this woman coming in? She is not a healthy patient at baseline. She was just hospitalized. There could be a lot of things going wrong with her. What kind of things did we investigate today?
Take first. It's pneumonia.
Pneumonia, okay. It's a good thought. Pneumonia, okay. Yep. Well, good thoughts. Okay. Okay. So we'll go with those. Going back, her vital signs make us concerned for sepsis, so we're concerned for some underlying infection. Her SpO2 is 89% on room air. She's supposed to be on 2 liters nasal cannula. And in somebody who has COPD, I'm actually okay with an 89%, especially in somebody like this who's recently had COVID pneumonia. That 89% without her home 2 liters nasal cannula is not terrible. She could have a urinary tract infection because she was recently hospitalized. She could have bacteremia. She could have a coronary event. She could have heart failure. She could have a pulmonary embolus. Something could be hiding somewhere. She could be having cellulitis or something intra-abdominally, DVT, dehydration, metabolic derangement, medication side effects. And we can also always think that she is just deconditioned because she was just in the hospital. So your physical exam, she is ill appearing, but she's able to speak to you in full sentences. And we put her back on her 2 liters nasal cannula, and now her oxygen saturation is 94%. And she's breathing a lot better. She says, thank you. Your head exam looks fine, except she has some dry mucous membranes. She's tachycardic with an irregular rhythm and has decreased breath sounds at the bilateral bases and some coarse breath sounds throughout bilaterally. Her abdomen, though, is soft and non-tender, but on your skin exam, because she came in still in her hospital gown from when she was discharged, she has a rash in her left groin. It doesn't have any induration or drainage, but you have a little bit of skin breakdown there. Otherwise, she has pitting pedal edema bilaterally, but nothing is asymmetric, and her neuro exam is intact. What lab work, imaging, or next steps would you like to take with this woman?
First get a complete blood count, and then we go to test her, get a chest X-ray and ABG. Maybe a urinary analysis. I'll get the procalcitonin.
Okay. Yes. Yeah, I think those are great first steps. Other things I might add is getting in.
Troponin.
Yep, troponin. Okay, maybe a BNP because she's got some pretty good pedal edema there. Maybe an EKG. I agree with you with the urine analysis for somebody who is hypotensive and she's pretty tachycardic and with an irregular rhythm when you put your hand on her. So I'd be concerned about maybe some kind of arrhythmia there too, which is why we want the EKG. And I agree with you, the troponin, the BNP. This is someone who I would get cultures on early. I agree with you with the blood gas and the chest X-ray. At an even more basic level, we've put her on her home oxygen, which needed to be done. We would establish access. This is someone I would make sure you have at least 2 points of access on her. And she's just mildly hypotensive. She already has signs of having fluid overload. This is somebody who I would go slower with your 30 mils per kilogram for fluids. So I agree that maybe she needs a little bit more in the tank, but you don't have to give her the full 30 mils per kilogram right off the bat, especially if we think she doesn't have great lungs. If she recently was admitted for COVID pneumonia, a lot of the times we were having patients run on the drier side. So we were using a lot of diuretics to keep the fluid off of the lungs. But otherwise, I agree with you for the inflammatory markers. This is somebody who I would also start thinking about empiric antibiotics sooner than later. But let's see what other information we can get from maybe an EKG first. Okay. So we said 2 IV sites at least, getting that EKG, your blood count, your metabolic panel, the troponin, a BNP. blood gas, including a lactate, your cultures, chest x-ray. I agree that this woman, I have a high suspicion for a pulmonary embolus with her recent hospitalization and COVID pneumonia. I would get some coags on her and the inflammatory markers and would start empiric antibiotics. But we also have to think about, there was that rash down there. And is this someone that you want to send to the CT scanner twice? Or is this somebody that we have to expand where our CT imaging goes? So just keep that in the back of your mind. We have this as her EKG. What are our feelings on this EKG?
Irregular line, low P1. So maybe atrial fibrillation.
Yep, I agree with you. Atrial fibrillation. You get a chest x-ray. Yeah, it's a throwback. I know many of our trainees were not around as much when we had such COVID prevalence. These are COVID lungs. We get these like diffusely patchy infiltrates, which is very consistent with COVID pneumonia. It didn't always correlate with how hypoxic a patient is. And a lot of times this is just scarring after the fact, and it takes a while to resolve. And some people still have chest x-rays that look like this. This doesn't signify that she's profusely fluid overloaded. We did a bedside ultrasound of her lungs, and there were not diffuse B lines. So this is, I think, just her baseline from when she was recently admitted. But yeah, this is not good lungs at baseline. She's at high risk for multiple comorbidities. But you start getting your blood work back before she's gone to the CT scanner. And oh God, yeah, she's a bit of a mess. She's got a pretty high white blood cell count, but luckily she's not anemic. Her platelets are okay. She's a bit hyponatremic. Her bicarb is 10, which doesn't bode well. Her AKI is new, so her BUN and creatinine are much higher than when she left the hospital 7 days ago. Additionally, you find her INR is 5. She said, "Oh, doctor, I didn't tell you I'm on warfarin, and maybe I took 2 of them this morning." So we have that as well. Her lactate is 7.8. That's pretty high. And we got a blood gas, and her pH is 7.21. She's pretty acidemic, and doesn't look like there is a significant respiratory component at this time, but I think there's a bit of a mixed acidosis for her. So with all of that in mind, what do you do next? That we have a CTPE to rule out a pulmonary embolism is on board. Do we want to broaden anything? Start any additional antibiotics? Or any other interventions or more information you would like to know about the patient?
Maybe sepsis.
Definitely sepsis. Yes, definitely sepsis. And kind of like how we talked about yesterday is that, you know, a pulmonary embolus is not going to cause this type of derangement. And when you don't quite know where something is coming from, it is okay to then get more imaging to get more information. So this is someone who now you have to go back and think, oh, maybe that rash in the groin isn't just intragenous candida. Now we have to go back and really look at the skin and do a very thorough GU exam on this person and send them to get a CT of their abdomen and pelvis as well, and make sure that they are fully undressed and looking at all of the extremities, looking at the back, and making sure that you're not missing anything, because this patient is very sick. So, and then also I would broaden your antibiotics if you haven't already. After getting all of this information, I would go back and check on the patient and make sure that the vital signs are still stable, because it seems like with this bicarb this low, a patient is at a very tenuous position that we've already seen that she's pretty fluid overloaded from her legs. So she's someone that I would start vasopressors on the earlier side while trying to give her more intravascular volume, especially because her lungs didn't look great. So you go back and you find this on her skin. So what we're looking at here is this area of discoloration. Yeah, here. And before you got your CT scan, this discoloration can also broaden your differential. If it was tracking up, we would be concerned about maybe a vulvar abscess. I'm very concerned right now about Fournier's gangrene. This skin discoloration in someone who uses warfarin, it would be a very odd area for it to be, but it can cause some warfarin skin necrosis. It is not normally in the perirectal area or perineum for warfarin skin necrosis, but it's something you have to think about in someone who is on anticoagulants. So you go through and you get your CT scan. She luckily doesn't have a pulmonary embolus. Her INR being 5, I would be surprised. But we do see some gas tracking perirectally and some stranding from this big yellow arrow sign. So now what do we do? Call your surgeons, yeah. And because of the region that's involved, I'm not sure for the process here. The United States, if it's in the perineum, oftentimes it will be not only your general surgeons for this region, but also possibly a urologist, depending on if it's tracking up near the urethra. They also like to be just nearby in case when they are going in and surgically debriding anything to see if it tracks up and if any other interventions need to be done. So, yep, you call surgery. What other problems did this patient have that we have to think about and manage until she is ready to go to surgery or the surgeons are ready for her?
We manage her acidosis and how to adjust the biotic.
Yep, I agree. So we'll adjust her antibiotics. We'll make sure that they are very broad, especially as she was just admitted to the hospital. You could think of her as someone who is possibly immunocompromised. In COVID patients, we do give Decadron. So she's been on a steroid for a while. She's likely been laying in a hospital bed. She has a fair amount of risk factors. You could also consider, it's unlikely that fungal infection is contributing to a necrotizing soft skin tissue infection, but you can think about adding an antifungal just to make sure that you are not missing an additional concomitant infection. But yes, I think the biggest thing is going to be making sure that your surgical colleagues can come down. In the meantime, we also have to think about her INR is 5.0. Surgery is not going to like an INR of 5.0. I think that may be the biggest one of the biggest hurdles in getting this patient to be accepted by surgery is likely her INR as well as her acidosis. As your anesthesiology colleagues are going to come down and they're going to say she's too acidotic for us to put under. It's too risky to intubate her because she's going to decompensate. So thinking about fluid resuscitation, vasopressors on the earlier side, even if she is not quite, if she's not hypotensive, is actually someone, even if she's still in the 90s, I would think about trying to help her perfusion status to see if we can decrease that bicarb and decrease that lactate to decrease her acidemia. And then normally we think about adding a bicarb drip in patients whose bicarb is lower than 10 or undetectable. This is somebody also who I would consider starting on a bicarb drip or a small amount to see if that can help change the electrolyte status and hemodynamics on her. And then for your INR, what kind of interventions can we do to help decrease her INR and help her get to surgery? So we can do vitamin K and maybe FFP, BCC, depending on where you are. Okay. So we did all of those things. We stabilized her for surgery, and luckily she made it to go to surgery. Her hemodynamics stayed stable, and you were able to convince the surgeon that she needed good source control. So what we've been talking about the last few weeks is mostly source control measures. So looking for the source of an infection and being able to remove that source of infection so that you can help your patient get better, and not just giving antibiotics without removing that cause for an underlying infection. So in these cases today, it was debridement of infected soft tissue, especially thinking about your patients who are immobile for a long time, looking for those decubitus ulcers, looking for skin breakdown. And then we talked about earlier in the month, foreign body removals or drainage of infected fluids yesterday when we talked about abscess. Okay. This specifically was Fournier's gangrene. So the necrotizing fasciitis in the perineal DU area has very similar risks to those for necrotizing fasciitis, but with increased risk in those who are obese, those who have periods of prolonged immobility, patients who we accidentally do this to, meaning they've been recently hospitalized and we've done Foley in there, or they haven't been rolled in a while, and they get small skin tears down in the GU region, and this can fester and cause Fournier's gangrene. Additionally, there's some literature that patients with a history of cirrhosis do very poorly and progress very quickly in the setting of Fournier's. And as we see over on the other side, potential sources of infection, most of the time is cutaneous, but then secondarily is urologic, either from underlying colonization with bacteria and the small trauma to the skin. Another thing to think about, especially in the population here, is how often people use motorbikes, and then small traumas or tearing with saddle injuries. Even if it's not large trauma, if there's small breakdown in the skin in the GU region, and then it's very warm here, can cause potential for developing Fournier's. Okay, so two types. We'll go through these pretty quickly because I know we're almost done with time here. So two types of necrotizing fasciitis, or three, depending on which literature you look at. There's one that is monomicrobial, meaning it's group-based strep, or due to Vibrio if your patient's been in fresh water or salt water recently, or Clostridium is common in obstetric patients. So patients who've recently delivered or have increased pressure down in the GU region. And then type 2 is polymicrobial, which is more common, meaning you're infected with more than one bacteria, which is why we are so broad with our antibiotics. It is typically either staph or strep, but you can also get a combination of E. coli and Clostridium with these as well. There has been more literature about ESBL, Klebsiella pneumoniae, also causing necrotizing fasciitis, with concern for which antibiotics that you can use. So this. And then things that I wanted to think about and discuss is which antibiotics do you prioritize? A lot of the times these patients are very sick. They are clamped down, meaning they don't have great peripheral access. And even when you get central access, maybe that is your only point of access. And sometimes your antibiotics can't run concurrently. You can speak to your pharmacist about which ones are compatible. And then depending on which antibiotics you're allowed to use, if they're compatible to run through the same line simultaneously. So the exception to this rule is like your first rule is that if you want to do your gram-negative and broad spectrum coverage, so your peptazos, your ceftriaxones, or your cefepime. And then next line down would be your vancomycin or your daptomycin for your broad spectrum. And then in the middle between those would be clindamycin. So when you're speaking to your nurse about which antibiotic do we prioritize, because you've ordered 3 antibiotics, doctor, which one do we start with? You start usually with the peptazo or the ceftriaxone, cefepime, and then move down to clindamycin. There is an exception to this rule over on the side here. And it says if clindamycin and penicillin are prescribed simultaneously, if that is what has been discussed for what your resistance pattern is at your hospital, those ones run them simultaneously through central line or through a Y tubing so that the patient gets both of those faster. But there's actually not really with, in regards to necrotizing soft skin tissue infections, about the priority. So we'll see if this one goes. Okay, it says that my connection is unstable, guys, so we will see if it goes to the next one. Does not. Okay, so quick words on the next slide. It's talking about surgical intervention, and that every 24-hour delay in surgery increases the likelihood of death by more than 9. So your patient is 9 times more likely to die every 24 hours that they are waiting for surgery. And the biggest correlation between improved mortality of your patients with this is how quickly they can get to surgery. So that means that it is on us to make a quick diagnosis and then to have a speedy communication with our surgeons. And just to note, this study here looked only at the time of diagnosis. That doesn't always account for at what stage your patient will present to you here. So a lot of times that's been before they even get here. But obviously down here, we do the resuscitation measures that we have control over and how we can help. So managing the hyperglycemia, managing the shock state, and managing how acidemic your patient is to try to make them stable enough to get to a surgery for source control. And then finally, there's some discussion about hyperbaric oxygen chamber therapy and use of Fournier's and in necrotizing fasciitis. And there are 2 studies here. And then the picture is from the hyperbaric oxygen chamber here in Ho Chi Minh City over at the Eye Institute. The first one was a meta-analysis of 10 randomized control trials that showed greater improvement in mortality for those who received hyperbaric oxygen therapy as compared to those with conventional therapy. And then the second one also focused on Fournier's and was a retrospective single center study, which had about 200 patients. And then those patients either who did or did not have hyperbaric oxygen therapy, and then what their outcome was. There was an association of improved mortality rate for those who received hyperbaric oxygen therapy. Those patients also had higher rate of having to go back to surgery for repeat debridement. So there are some conflicting factors in here about, how sick is the patient stable enough to be able to go over to a hyperbaric oxygen chamber, and if one is available. It's just something to think about for wherever anybody practices. Okay, and so in summary, the necrotizing soft skin tissue infections have a very high rate of mortality. Our job is to focus on early identification, getting a good history and addressing your patient and doing a very thorough skin examination, getting early discussion with your surgical team or teams, getting multiple sites for providing your patient with antibiotics and resuscitative measures, initiating broad spectrum antibiotics and discussion with your pharmacist about what those antibiotics look like for each of your sites, and then frequently reassessing to make sure you're not missing a decompensation or a shock state. Okay, thank you. Any questions? No. Okay, and then just for the diploma candidates, I know we have a lot of learners in here, but those who are part of the diploma candidate, Dr. Shakira Bandolin sent out an email this morning for a mid-year pretest and a survey. If you're able to fill that out before the next session, next Thursday, we'd appreciate it. And thank you, everybody. I'm going to turn it over to Dr. Hanna.